This is Roadmap to Resilience, an audio series for professionals and families who are supporting children experiencing stress and trauma. I'm Dr. Julian Ford.
And I'm Dr. Amanda Zelahusky. Whether you work with children or you have children of your own, this podcast is for you.
As we continue to talk more about how professionals can help children and their families foster resilience during or in the aftermath of trauma, we're going to focus on healthcare providers, and that includes pediatric, family medicine, nursing, and other medical and allied health professionals.
We're going to focus on an individual and a systemic level. As we'll see with our first expert, even if healthcare providers have all the education and the best of intentions on how to provide trauma-informed care, if they don't have a system to support them, then implementing these ideas into their practice can be a challenge.
Our first expert is Dr. Brooks Keeshin, who's an associate professor in the Department of Pediatrics at the University of Utah and a child abuse pediatrician and child psychiatrist. He also delivers trauma-focused psychiatric care as part of a multidisciplinary treatment team.
Dr. Keeshin is going to tell us a bit more about the process of running a practice and, in fact, a system of practices that provide trauma-informed care.
So what does a clinic or a practice look like when it is prepared to help parents if they disclose that their child has experienced trauma?
So what we've had the fortune of doing here in Utah, we've engaged in a partnership with Intermountain Healthcare. And that partnership has resulted in piloting a care process model, so a systematic way to identify and respond to children specific for traumatic stress. And that care process model included both traumatic stress as well as suicidality. And we started that with 2 clinics. And what we did with those first 2 pilot clinics is we spent a ton of time with them figuring out what does the clinic itself, everyone from the front desk to the nurse managers, to the MAs, to the physicians, what knowledge do they need to know about trauma so they understand why we're doing this in the first place and the importance of it. What do they need to understand about workflow to make sure that we can get from A to B and not wreck the entire clinic, because there are other patients that need to be cared for. And then what does the clinic need to meet the needs of their population in cases where there are positive responses, either specific safety concerns because of the trauma threat is still ongoing, or concerns related to distress and to suicidality, or specific to what do I do with a kid who's got a lot of traumatic stress symptoms? Who do they need to go see? And so we worked with those clinics to identify who were their community partners? Not just refer to mental health, but refer to the right person within mental health who is capable of doing a trauma-informed assessment and delivering evidence-based trauma treatment when appropriate. Who in their community is available for social supports, addressing social determinants of health, so specific needs for those families. And then how do we kind of set up kind of the quote-unquote protocol so that we're not scared of positive responses, but rather when we get positive responses, it can start a conversation where the pediatrician can align with the family, validate their experiences and help them kind of understand what the possibilities, what the next steps are. But then doing those possibilities and next steps doesn't ruin clinic. You just plug them into the things that you've already designed to help with that particular condition. Just like we do if a kid's got a fever and you do a rapid strep and you find out that they have a strep infection, we don't reinvent the wheel. We send them to the local pharmacy and they get their, strep appropriate antibiotic. So it was trying to think through all of those pieces. And when we did that with those first 2 clinics and we showed that we were able to do that, then we expanded to 5 more pediatric clinics. So not the early adopters, the folks who were so gung-ho about trauma, but we did it with folks who were interested, willing, but didn't want to be the guinea pigs. And we repeated that both internal process, as well as we repeated the external process and linkages. And we made sure that those were working. And we built in feedback loops to make sure that those processes were solid and strong and helpful. And as a result of those clinics, so Intermountain has about 20 primary care clinics for pediatrics across the state of Utah. By the end of the year, we will now be doing this trauma screening and response in all 20 pediatric primary care clinics. Because we did it in a step-by-step fashion, we made it so that the screening was feasible, as well as it gave you the answer you needed. It gave you a actionable decision point that the pediatrician and the family could look at together and decide what the right next step is. And we made sure that the internal environments of the primary care clinics, as well as the external environments that surround and support those pediatric clinics, were all set up to actually receive those families and to coordinate back with primary care. But it was a multi-year process. It was not like turning on a switch and saying, "Oh yeah, we'll just start a little trauma screening and then things will go great."
That's a great blueprint. So I have one practical question for you. Mm-hmm. Does every pediatrician and every pediatric nurse in each of those 20 clinics have a phone number or a set of phone numbers that they can call if they need to make an immediate referral because they identify a child who's experiencing significant suicidality or significant traumatic stress difficulties?
Yes. Yeah, so that is all built into the process. So there was already a suicide prevention care process model for primary care that was already in existence. We basically adopted that within our own model. So, remarkably, it's easier for folks to kind of do one thing than to ask them to do 47 different things. Mm-hmm. So we tried to build in the crisis suicidality response, recognizing that in a primary care population, many of your suicidal adolescents, if not most of your suicidal adolescents, actually have significant trauma histories and oftentimes have ongoing traumatic stress symptoms. So this idea that they're really different populations in primary care isn't true. We're really talking about the same kids. And so then what we did was we built upon two different avenues of support specific to suicidality. Let's do what works really well in primary care, which was both utilizing a risk assessment measure. So we did the Columbia Suicide Severity Rating Scale. So making sure that everyone was trained and felt comfortable with that so that we could triage those low to high risk folks so we can identify, Julian, the ones that you're talking about. And then for pediatric clinics, they all had to come up with their own specific, what is our next step? Some of these pediatric clinics have therapists that are actually integrated within the clinic. So there's someone they can go to down the hall. Nice. Others don't have those clinicians every day, or they don't have them at all. And so, well, then what are the local resources that we can use? Short of going to the emergency room, so a crisis number, helplines, engaging with a local mental health authority for an urgent same-day visit type of thing. And then, of course, utilizing the EDs when necessary. So, that kind of being when there's an acute safety risk and there's no other means to address that safety risk without the confines of an emergency setting, then utilizing that as appropriate. And that has worked really well. We've started working to encourage pediatric clinics to actually take on more of a role when it comes to lethal means counseling and initial steps in safety planning. So as we've done this work, we've actually started to now build their skills, but we didn't thrust that upon them all at once. Mm-hmm. It wasn't like, we're going to address suicide now, and we're going to turn every pediatrician into a crisis worker. But instead, we started with the Columbia, and then we started to, with their comfort level with that, then started to build upon that in terms of, well, how can we do some improving the safety of the environment? So with lethal means counseling. And then, of course, how can we actually start to engage families by doing some safety planning within the pediatric setting? And that seems to have been a much more palatable approach than kind of the, let's get it all done at once.
There is a certain sometimes protection of the medical professional. I don't want to burden you, or whatever that case might be. But I also think there's avoidance in the other direction, that in conversations I've had with medical providers, schools, systems that aren't the traditional mental health system, that they'll say, okay, so if I ask about this stuff, what am I supposed to do with the information then? Now what? And so I want to ask you about the avoidance maybe in the other direction, and your thoughts for your, fellow medical providers around not only that we should be asking, but then what do we do with the information that we get?
So pediatrics, if you do all the things you're supposed to screen for, according to Bright Futures, which is kind of the pediatrics Bible for preventative care. I think it takes somewhere in the range of 6 to 8 hours for a visit. And I'm sure there's some hyperbole within all that, but it's true that there just isn't enough time to be screening for all the things. And so if there's something that has the potential to be a Pandora's box, even if it's at the subconscious level, if there's a way to kind of tiptoe around it, sometimes that's natural, normal human instinct. We've done this with depression. We've done this with suicidality. And I think equally so, this is an issue with trauma. It's a little bit of a mixed bag, right? Because pediatricians in general understand their responsibility as mandated reporters when it comes to child abuse. That's not to say that pediatricians do it perfectly and that they report every time that they should. But that is something that really is part and parcel within pediatrics. But you take it a step further and you open up that potential Pandora's box around trauma or around suicidality, and you haven't empowered that clinic to know how to respond. It makes perfect sense that I'm going to take care of the things that I need to do, that the family is asking for. It's a well child check. They want to know, is their child healthy? So I'm going to do that. And I'm not going to go the extra. I'm not going to go down these roads that if it's a no, great, it doesn't wreak havoc on my clinic. But if it's a yes, oh boy, Mrs. Johnson in the next room with the twins, that's not going to go well. It's going to back us up in 3 clinics and I'm going to miss lunch again. So I do think that's a real piece to it. If we want to talk about that later, that is part of the reason why I think preparing a clinical setting and figuring out what the responses are so critical to being able to do trauma-informed care. If you just want to do trauma-informed care, but you don't have the systems in place internally within your clinical setting, and you don't have the systems, the connections external to your clinic to make these appropriate connections and linkages, it does wreak havoc on your clinic. That is true. And so it's really important that when you want to develop something that you think about not just how do you screen or how do you start the conversation, but then really how do you respond in an effective, but frankly, efficient kind of way. Kids get seen in primary care. They go for their regular well child checkups that they get before school. They go for their vaccines, which are even more important these days. They go for sniffles and colds and infections and all that kind of stuff. So pediatricians really need to recognize that they're part of a multi-system response, and oftentimes they have that longitudinal connection with families. They understand kind of the trials and the experiences of families from years ago and how that relates to what's going on now. And they're the ones that really have that power to say in a very confidential and welcoming and supportive environment, we recognize that life events really can affect how kids are doing. And so it's important for me as I'm taking care of your child to know if anything stressful or scary or traumatic has happened. And this is a place where we can talk about that kind of stuff and just opening the door. Because if they're not doing that, if they're just kind of assuming that if it's really bad, the parent's going to let me know, that's kind of where we get into this kind of false sense of security, basically, that essentially we're expecting our families to understand, one, what trauma is, when frankly we have a lot of educating to do to make sure families actually understand that, and two, to actually make the cognitive connection that the life experiences that my child has had is actually directly impacting how my child's health is, or how my child's mental health is, or how my child's functioning is at school or at home. And that's really a lot to ask families. Some families are on it. They come in, they say, this is exactly what's going on, and this is what I need help with. Great. But the majority of families don't fall into that category. So it's that awareness and recognizing their role that, if we're relying on child welfare in the schools and all the other systems and mental health, we're missing a great opportunity to start those conversations, to inform families and to help families kind of decide what their pathway is when it comes to supporting the resilience of their child, or in terms of getting the help that their child needs to get back on track.
From the standpoint of pediatrics, you have a particular advantage too, because it's not just physiology and then pathophysiology, it's developmental stages or phases or processes. So as kids go from early childhood through later on in childhood and adolescence, as their development changes and their physiology changes along with the development, then you have that perfect kind of opportunity to say, well, these are the benevolent experiences that promote really healthy development, and these are the adverse experiences that can really interfere with that. So it's not just a concept of overall, but it really is linking that to stages of childhood and adolescence development.
And it's what makes pediatrics so exciting. I mean, I like adults, don't get me wrong, but much of development has already taken place. Not all of development, but much of development has already taken place by the time, we're all talking together on a podcast. Whereas it's just so exciting to be able to do small things or big things that truly change trajectories. The potential, to take a second grader who's struggling and to get that to a fifth grader who's loving school and having a great time at home. What's the potential for that fifth grader when that fifth grader enters freshman year of high school, relative to if that second grader who kept struggling just not only continued to struggle, but then developed that identity of, well, I'm just someone who struggles. And so the developmental potential is just so exciting. I think all of us pediatricians feel like we are so privileged to be able to interact with families at that period because of the potential for change.
So Dr. Keeshin is giving us a really important reminder that trauma-informed care really involves the entire healthcare organization and involves all of the practitioners, the staff, everyone who's involved in the care of children's physical health.
Our next expert is Yehudis Stokes, a nursing professional and PhD candidate at the University of Ottawa. She works with the Children's Hospital of Eastern Ontario to implement a trauma-informed care model at the hospital.
Yehudis reminds us of the crucial role played by nurses in recognizing potential sources of trauma and supporting children and families as they receive healthcare services.
She had a lot of wonderful things to say, including related to the necessary manner and mindset with which we approach children and families who have experienced trauma. This is applicable not just to nursing, but to all healthcare providers and professionals who support children. So here is Yehudis Stokes.
From what you have learned and from your experience as a professional, what are the essential elements of trauma-informed nursing care?
So when we say trauma-informed nursing care, I would just like to highlight that I think trauma-informed care needs to be across an organization and not only within a specific discipline. Nurses have that opportunity to create the framework for care as providers that spend the most time present often with patients on an inpatient unit. They're continuously assessing and getting to know the patient's needs and have an opportunity often greater than other providers or professionals to get to know who the patient is. They're also the central coordinators of all of their services that the patient may receive. So the nurses really have that opportunity to discover who their patients are, to work to provide a safe forum for communication, to get to know their patients, and to be able to relay that information and advocate for their patients and families in the services and in the care that they receive.
For you as a nursing and a mental health professional, what have you found is most important that you can do to help a child who is hospitalized and is separated from their family, to help the family? And then what can the parents of that child do? And how do you help the parents help the child?
I think in this rushed world, particularly the rushed world of healthcare, one of the most important priorities to remember is taking the time and the awareness to be present. And I actually think of the 4 Ps that are listed by the neurosequential model of therapeutics, and that is to be present, patient, parallel, and persistence. So being present, as I explained, not only being present physically, but being present emotionally, being present in our minds, and taking that opportunity to actually be with the person that we're with, whether they're able to connect with us or not. Being present is so important. Being patient, knowing that we can't always expect an immediate response to our questions or to our gestures, whether it's even just a few extra moments to take, to be with them, to wait until they feel safe to open up, to wait until they feel safe and comfortable to respond, and to be patient also with their journey through their mental health recovery, physical recovery, to acknowledge that everyone is taking their own pace, to be parallel. So we sometimes lose sight of the value of being in parallel with another. We think that if we're not actively engaged with them, or they're not actively engaged with us, that there isn't value to doing things side by side, doing things in parallel. And that we know with normal childhood development that children will play in parallel before they play dyadically together. And that's an important part of the process of getting comfortable being side by side with someone before actually engaging together. And so I think that's an important step to keep in mind, that even if someone is not engaging with us, the fact that we're with them and that we're doing actions in parallel with them is a very important step to lead to engagement and communication. So being present, being patient, being parallel, and being persistent. Being persistent in providing these safe, engaging experiences, even if you don't receive the feedback from the child or from the other that you're hoping for or that you're expecting. Being persistent in our patience and our presence and our being parallel, knowing that there's outcomes we may be hoping for that we may not be seeing immediately. And the important part is to be consistent and continuously offering these opportunities for safe, engaging experiences, even if we're not seeing the outcomes we're expecting, because we'll get there, but it will just require persistence. One other sort of acronym that came to mind when I was thinking about approaching patients from a trauma-informed lens was that of taking opportunities to respect, connect, collect, reflect. So RCCR. And similar to the 4 Ps, being respectful means being present and being respectful of who the person is, where they're at right now. And through that respect and that regulating environment, providing opportunities to connect, for that person to feel safe to share. And through that respectful and open communication, we're able to collect more information than we would have been able to without that safe space and that safe avenue of communication. And so through that respect, connect, collect, we can then take that information and reflect on what is this person sharing with us? What do we now know about this person that helps to put them into context of their lives and where they're at right now? And so if we skip these steps of respect, connect, collect, reflect, or any of those steps, then we're going to miss links in getting to know who the person is. And we'll be left again with the person in front of us, but also layers of curtains in front of us, blocking our view of what the patient really needs and who they are at this time.
I was thinking about the dilemma, and I wonder how do you approach this dilemma when a parent, let's say particularly when a mom is experiencing really severe postnatal depression and just doesn't feel able emotionally to connect with her infant, her baby. What have you found? What do you know that is most important in helping that mom and that mother and that baby?
That's such a huge question.
While you're thinking, Yehudis, I mean, one thing that just came to mind as you were saying that, Julian, is just all of the ways that, I mean, I can remember, after having babies and being in the hospital, that nursing staff and hospital folks help you think about the many ways other people can fill those buckets. So if they just keep telling you, let us help, let us do this, I can do that for you, let people in your life help. So it was like those reminders I remember as a new mom that I felt like gave me permission when I was impaired in some way, exhausted, whatever, that you don't know that that's okay because you think you're a new mom and you're supposed to have to do all these things. But I distinctly remember nurses encouraging me, very experienced, saying, now let me tell you how this is going to work. You're going to go home and you're going to let people do this stuff for you. And so I just wonder if maybe that helps spark any thinking for you, Yehudis, about how much you're also helping others realize the importance of letting community step in those situations when you might be
a fifth P, permission.
Yeah, right. I love that. Right. I wish we didn't need it, but we're so socialized to feel that guilt, like you're supposed to just know how to do this because you just gave birth to a baby.
I think absolutely. I completely agree that maybe we need a fifth P added to our 4 Ps of receiving permission to take help and receive support from others, from our friends, from our family, from community providers, that there's no shame. And it's actually really important for us to receive that support, both for us managing these tasks on a physical level, on an emotional level, as well as continuing to build those relationships and receive rewarding experiences through relationships, and reminding us that the power of relationships. And often through trauma, we learn that our relational supports are not there. We lose trust in those supports and we begin to look internally to manage all of our stress, whether it be to fight or flee, or to really look internally in more of a dissociative capacity. And I think an important part of healing from trauma, from big trauma, from small trauma, from our worldwide culture of trauma, is to continue to engage in safe and supportive relationships, to support others, to receive support from others, and to bring us back to that natural tendency of looking towards relationships for support.
And I want to be clear that I'm not in any way suggesting that a mother who is depressed is traumatizing her child. Mm-hmm. And in fact, that may be one of the most important things for us as professionals, to be able to help parents who are struggling with emotional difficulties. And postpartum depression is just one example. It's a very powerful one. But for those parents who really want to forge an alliance, an attachment, a connection with their child, but feels emotional barriers that are not of their own choosing and not because of anything they've done that's wrong. For those parents to know that it's not that they're in any way traumatizing their child, it's that they're going through a process of regaining that sense of being able to just feel connected and attuned. And I would think that the 4 Ps that you described on the part of the professionals could be very important there, because it must be so crucial to be able to be present and patient with a parent who is deeply distressed and who isn't connecting with their child. That could easily lead to just desire on our part to intervene and push the parent to be closer, be kinder, feel something different. My guess is that that's exactly the opposite of the approach you would take.
Yes, I believe in applying those 4 Ps to working with the parent, and encouraging, navigating resources to support the parent in terms of where they're at. And equally important, ensuring that there are resources to support the child as well. So, of course, prioritizing the care of both individuals. If the mother's not able to provide that attunement and care to the infant at this time, to ensure that maybe there are other family supports there or other individuals that can help support her as well. In years gone by, we used to live primarily in intergenerational homes, which provided many adult caregivers for a child that was born. And I think now we live more and more in isolation, where we're left with that responsibility on our own as a mother to care for this child. And I think being able to open up to those ideas from the past of having multiple caregivers available, particularly when a new mother is recovering from physically and emotionally from birth, is an important idea to consider as well.
So present, patient, parallel, and persistent. What a great way for us all to remember, some of the most critical aspects of providing care to children and families who've experienced trauma.
Our final expert in this episode is Dr. Dave Corwin, who's a professor at the University of Utah Pediatrics Department and the immediate past president of the American Professional Society on the Abuse of Children.
Dr. Corwin was able to speak about how healthcare providers in general, for children and adults, can better care for their patients through more active communication and for themselves as they support patients through really difficult circumstances.
Self-care for healthcare workers is so important. I'm really glad that Dr. Corwin touched on this so thoughtfully. So here's Dr. Corwin.
If I'm a healthcare professional and I want to be more trauma-informed and trauma-aware and help these really vulnerable kids and families, what are some maybe shorter-term, quick things that I can implement in my everyday practice right now?
Well, the first thing you can do is get more educated so you can earn some of your CME credit or your CEUs by going to one of the webinars or go to the whole series created by the California ACEs Academy and on the ABA website, abahealth.org. It's free. Get educated. And then make it, as you learn more, begin to integrate it into your practice. Ask the question. Make it clear to your patients that you understand and care about the things that have happened to them in their lives or may be happening in their life now and in the lives of their children that have important health ramifications, and that you're open to addressing those. You have knowledge, you have systems that you're connected to and that you know about. You can help. And if you can't, you know somebody who might be able to.
So let's get right down to the most practical question of all, which is if a healthcare provider is knowledgeable, opens the door, and then learns something about a child or an adult patient that is deeply disturbing to the provider, what should the provider do then?
Well, it starts with listening. Listening, as Dr. Felitti realized and wrote, is doing. Just witnessing, just hearing, and respecting what you hear, and staying there and helping in small steps. You can't solve everything all at once, but you can listen. You can keep things on the table. You can address the problems related to something that may be much larger incrementally over time. You can break it into manageable steps. And the one thing that our healthcare system is designed to do well is to treat symptoms. We know how to treat symptoms, but it helps if we have a more global understanding of how these symptoms are connected and we're addressing the underlying drivers and not just treating symptoms. For example, in psychiatry, what happens to highly traumatized people, they have a lot of symptoms. And so they end up with a lot of psychiatric diagnoses. And there's a tendency to treat every psychiatric diagnosis with a different medication. And you end up with so many medications that even a supercomputer can't calculate all the possible interactions and adverse effects. And that has problems. Understanding what is causing a variety of symptoms is an important step toward then beginning to address them in a logical, efficient, parsimonious way. And doing so in a caring relationship over time, which also requires that we build and structure our systems so that there is relationship and there is an opportunity for listening, and it is valued, and it is reimbursed.
Well, along the way, you just answered my question as a very responsible and very patient-centered provider. Now I want to turn it around and ask the question, what should the healthcare provider do for themselves when they are shocked, dismayed, horrified to hear things that have happened to a vulnerable child, for example? How do they take care of themselves?
Absolutely essential question. And, the first metaphor that comes to mind is what they say to you on the airplane. When the oxygen masks deploy, put yours on first, then help your child and others around you. If our healthcare providers are overwhelmed and so troubled that, by the things they're hearing or dealing with, they can't function. That's not good for them, and it's not good for their patients. And what I have found after more than 40 years dealing with child maltreatment and serving for 13 years as a medical director of a children's hospital child abuse program is one of the most helpful things to those on the front lines is to be able to talk to people who can understand. And that's others who do similar work or do the same work. What you can't do is you can't take this home. You can't go home and talk to your spouse who is not as habituated as you are. It's traumatic to them, just like it's traumatic to us. And there are still things that I encounter as a professional working in this field that are overwhelming, that I have to call up a friend and colleague and talk about because I can't keep it inside my own head. I need help. I at least need to get it outside. And see, our patients do need that too. And some spend their whole lives holding inside some very horrible kinds of experiences. And just the experience of being able to share it, even though it doesn't take it away, it's still there. It'll still be troubling and upsetting, but it helps. We are on this journey together. What a privilege, to have in our lives, to try to carry this forward and make the world a little better place than before we came to it through this particular understanding and area of knowledge.
Healthcare is something that we all need and that we all receive. And when children and families have experienced trauma, the healthcare they receive from people from so many professional disciplines and backgrounds is absolutely crucial. And in that healthcare, when those providers recall and recognize and are able to be present and patient and parallel and stick with persistently the care and the needs of those children and families, some remarkable things happen. It's not just physical health that is in the balance here. It's also the ability of that child and that family to recover and be resilient psychologically, emotionally, and in all areas of their lives. Healthcare can provide so much through trauma-informed care. I'm just so glad that we are able to hear from experts who are doing that every day and who are making that difference in so many children and families' lives.
We'd especially like to thank our healthcare guests on this episode, Dr. David Corwin, Dr. Brooks Keeshin, and Yehudis Stokes.
Visit roadmaptoresilience.org to learn more about our guest experts, access additional videos and resources, or send us a message.
If this episode piqued your interest, we'd love for you to leave a 5-star review on Apple Podcasts and let us know what you think. And if you imagine this episode would resonate with a colleague or friend, please share it.
Roadmap to Resilience is a collaboration between Pandemic Parenting and the University of Connecticut School of Medicine, with special thanks to the Interorganizational Child Trauma Task Force.
Roadmap to Resilience is produced by my co-hosts, Dr. Julian Ford, myself, Dr. Amanda Zelahusky, along with Carmen Vincent and Victoria Bruick. Many thanks to Jennifer Valentine for her strategic support and to the teams at Pandemic Parenting and the Center for the Treatment of Developmental Trauma Disorders for providing promotional support.
We'd also like to thank the Substance Abuse and Mental Health Services Administration's National Child Traumatic Stress Network for their financial support of this project.
Thank you for joining us in supporting children in need of a roadmap to resilience.